Hello all, my name is Dr. Gaurav. I'm one of the consultant psychiatrists practicing in India and I'm also a tips resource person. I'm going to discuss with you in this video about what I found new in Maudsley's 14th edition in schizophrenia and related disorders. In the first chapter of Schizophrenia and Related Disorders Antipsychotic Prophylaxis, the guidelines I found were quite practical to small and medium income countries, in which there's a high chance of losing the patients on follow-up. So they have also discussed the probability of use of a depot antipsychotic in the acute phase of the illness, which is quite practical if it is personalized to the patients. And they've also advised something called as hyperbolic tapering of the medicine. It means that initially the percentage of reduction of the dose should be high and then later on the percentage should be reduced. So which is also something which I found new in this edition of Maudsley. And they've also told that something like supersensitivity psychosis is a phenomenon which was quite uncommon before, but it is quite common now. So, in simple words, supersensitivity psychosis means if there's a lower dose, there's a higher chance for psychosis. For the negative symptoms or the deficit symptoms, for the first time, they have advised the use of amisulpiride and cariprazine, which was not seen in the previous editions of Maudsley. And they've also advised the use of olanzapine and quetiapine, but however they have lesser evidence as compared to amisulpiride and cariprazine. Obviously the clozapine is one of the best options which stands alone. Drugs acting upon NMDA receptors have also been tested. For example, there are some negative randomized control trials for serine, D-glycine, modafinil, R-modafinil, and even augmentation with bitopertin, which are the newer agents. There is a small preliminary positive randomized control trial for pregnenolone. The findings from studies of repetitive transcranial magnetic stimulation are mixed but are promising for schizophrenia. The evidence for transcranial direct stimulation as treatment for negative symptoms is limited and inconclusive. So there is no much difference in the practice of the current guidelines in psychiatry from the previous practice guidelines. I have tried to summarize monitoring the adverse effects. These guidelines are common to United Kingdom and other countries as well, but however some countries might have minor variations. Urea and electrolytes have to be tested only once at the time of admission. However, we have to be careful about amisulpiride and sulpiride because of their potential nephrotoxicity. The full blood counts have to be done yearly, but however, we have to be careful about clozapine and we have to be careful about agranulocytosis when these guidelines change. Blood lipids and weight have to be monitored at the time of admission or at the time of OPD. We have to do it 3 monthly for first year and then yearly. We have to be careful about clozapine and olanzapine. Glucose has to be done at the baseline at the time of admission, or if we are suspecting that second generation antipsychotic might impair blood glucose. But we have to do it for 6 months for clozapine, olanzapine and chlorpromazine. So, in first episode Schizophrenia, we have to follow 4 principles. Number 1, we have to choose the antipsychotic. It should be a common consensus. And in case we are not able to come to a consensus, then we have to use second generation antipsychotic. Number 2, we have to start the minimum effective dose of the medicine. Number 3, we have to wait for 2 to 3 weeks and see. Number 4, if the patient responds to medicine, then we have to continue this medicine for some time. If the patient does not respond to this medicine, we have to start the 4 steps all over again. Or if the patient partially responds to medicine, or the patient cannot tolerate the medicine, then we have to choose the medicine according to the patient, or we have to use a long-acting injectable. In these guidelines, the author as well as the practice guidelines, they give us the choice of choosing the medicine, which has to be personalized according to the patients. In case of multi-episode schizophrenia, the choices become little limited, and then we have to change our approach. So I have divided the approach for multi-episode schizophrenia into 3 simple steps. Number 1, we have to assess the psychosocial factors which might have affected the outcome of the illness. Number 2, we have to discuss the medicines with the patient, and we have to see if the patient takes the medicines regularly. And then we have to wait. Either we can provide a sedative to a patient, or we can choose the medicine which is more acceptable to the patient. Number 3, if none of the options are acceptable, then we have to use clozapine. Clozapine is also the drug which is chosen if 2 different antipsychotic classes of drugs are not effective in case of treatment-resistant schizophrenia. To summarize, we have to be very practical in giving the medicines to the patients. While tapering the medicines, or antipsychotics in particular, we have to use hyperbolic curve. We have to be careful about supersensitivity psychosis, which is an emerging phenomenon. We have to use clozapine if 2 different classes of antipsychotics have not worked, or we have been giving the medicine for a long period of time and it has not been working, like in case of multi-episode schizophrenia. Thank you all for patiently listening to us. For more information relating to this topic, you can ask us on our Telegram group www.tips.co.in, or you can personally send me queries on the email ID which I have provided. Thank you. Have a nice day.
Created using Powtoon.